Hello, everyone. This is Bray Patrick-Lake, and I'm here with Dr. John Carroll, who is an interventional cardiologist at the University of Colorado Hospital, and we are just about ready to start our broadcast for Heart Month. So we will be counting down. We're obviously in the home stretch of Heart Month with a lot of great information going out through ZubiaLive to patients and interested parties, people who are managing conditions and some who just have interest in health and wellness. But again, so I am Bray Patrick-Lake, and I'm a patient with PFO, patent foramen ovale. So PFO is the common acronym that we use, and today we'll be talking about the heart-brain connection. So I think that's kind of an interesting link that we look forward to exploring. And so Dr. Carroll, if you could tell us a little bit about yourself and how you became a world-renowned PFO expert.
Well, first of all, I perform procedures on people with various cardiac issues to try to help them. And it was a little over 15 years ago, this area was emerging that perhaps this remnant of the fetal circulation that's present in 1 out of 4 adults may be a pathway by which a small blood clot that would normally go to the lungs and be filtered out could make it over to the left side of the heart and then go up. And it only takes a 2-millimeter clot to occlude the middle cerebral artery, and you become all of a sudden hemiplegic and potentially not able to talk. So that's really how it started, and it has been a conundrum for a long time in the sense of, gee, how do we prove this? Is closing a PFO beneficial? What other kinds of problems can people have who have PFOs? And is it really a disease, or is it just in a certain small group of people who have PFOs that they have problems? So that's sort of how it started. And being in an academic medical center, you realize we really have to get firm answers to these questions. We can't just kind of do things, well, it sounds good to do, close a PFO, because it would be really wrong to, with potentially no benefit to the majority of people. And while it's a relatively low risk procedure, it's not zero risk, and it is implanting a permanent device in someone's heart. So that's how it got going and how we all got engaged, and that we needed some scientific evidence to help people make decisions.
Yeah, and I think that's a great theme that we need to talk about. So I was a patient who was experiencing a number of things you talked about where I didn't know I had PFO, and I had basically a hemiplegic episode that then I went through a full workup for stroke. I was also pregnant at the time, and really just trying to understand how the heart brain, even, how they were connected. I was also having migraine, and how, migraine kind of played into this. Turns out in my case, I didn't have a stroke, but I also learned that, we really didn't have good answers for patients at the time. And so I enrolled in a clinical trial that actually brought me to your office, and then ended up getting a device that was implanted in my heart, which brings a whole other, whole other host of issues of living with a device and the decision making, to actually decide whether you want to close this hole or not. And I think we should let's talk through the diagnosis, because it's not just learning that you have, this common hole in the heart condition. And I know it's not really a hole, so maybe you can speak to the anatomy as far as it being more of a tunnel-like structure.
Sure. Well, you have to go back to when we were all in our mother's womb. Our PFO, everyone has a PFO, and it's widely open because you're receiving oxygenated blood via the placenta, and it comes up the inferior vena cava, and there's no point of the blood going to the lungs because you're not breathing when you're in utero. And so the PFO is open, and the majority of that blood goes right across from the right to the left atrium, which is where this wall is that has the flap called a patent foramen ovale. And when we're born, when we take our first breath, our lungs expand. Now blood goes to the lungs. The pressure in the left atrium becomes slightly higher than the right atrium, and this flap closes. And on 3 out of 4 people over the next few years, it fuses shut, never to be open. But in 1 out of 4 people, it doesn't fuse completely shut. So that flap is capable of opening. And that's part of the challenge in making a diagnosis that someone has a patent foramen ovale, is you've got to do something to show that blood can go from the right to the left atrium. And the most common way is to visualize the heart with ultrasound and then inject through a peripheral vein, an IV, agitated saline that contains microbubbles that really show up on ultrasound. So when they hit the right atrium, they should all go to the lungs, and the lungs filter and no bubbles go to the left side. But if you've got a patent foramen ovale and you can get it to transiently open, then all of a sudden those bubbles appear in the left atrium, and that's the presumptive diagnosis of a PFO.
Okay, so excuse me. So that is would that be a transthoracic echocardiogram?
Yep, on the chest.
So some people call that a TTE, and then there's also a TEE, which is
kind of the next common test to do. And so it's putting an echo probe down the esophagus. It's not too pleasant, so you get sedated. And why is the esophagus a good place for an echo probe to show more detail about the PFO? It's because the esophagus is right behind the heart. So you get these very pretty clear pictures of the heart, and specifically that wall, what we call the intraatrial septum. Septum is just our medical term for a wall. And we can see, is that wall complete? Is there a hole, which would be a congenital ASD? Or in fact, is there this flap where there are two components, a thin part that's called the septum primum and a thicker part called the septum secundum. And we see, are they fused or are they open? And then we also look at the septum primum, this thin, and see if is it moving around excessively. If it moves more than 10, 12 millimeters, then we call that an atrial septal aneurysm, which sounds terrible, but that's what it means, is just extra tissue that's kind of moving back and forth.
And so the atrial septal aneurysm, is that considered to be something that increases risk of opening the PFO?
It's associated highly with having a PFO, and while PFOs occur in 1 out of 4 adults, atrial septal aneurysm is probably only in 1 or 2% of adults. So it may not truly be an abnormality, but it is associated with larger PFOs, and it is associated with a higher risk of what we call a paradoxical embolism. So it is a feature we look for that may signify a little different anatomy than the 1 out of 4 people who have quoted garden variety PFO, and it's of no physiologic importance.
Okay, so it's starting to become a little more clear, but we are using some pretty big words, so paradoxical. How do you explain that?
So let's talk about paradoxical embolism, because it's really at the fundamental crux of the mechanism by which a stroke could occur that may be PFO related. So an embolism is a blood clot floating in the bloodstream and heading somewhere. A clot that, say, starts in the pelvis or in the leg from a deep venous thrombosis is called a thrombus. And a thrombus is fixed someplace, and then it breaks loose, becomes an embolism. And if it travels up to the heart, to the right atrium, and if it can pass through this patent foramen ovale and end up on the left side of the circulation and cause a stroke, we call that a paradoxical embolism, because it started in one part of the circulation, but then it ended up in another part, and that's the paradox. And that's the mechanism by which we think PFO-mediated strokes occur. And again, these are very small clots, and so it's not, people don't have to have an underlying clotting disorder. And we sort of think of the lungs as a great filter organ for tiny little debris, and so the patent foramen ovale gives a way by which little debris, little clots could bypass the lung filtering mechanism.
All right, so thinking about the debris, this is maybe a good time for us to talk a little bit about migraine and its relevance to PFO. I've heard, I guess, hypotheses about vasoactive chemicals that could potentially cause migraine. So could you speak to that?
So many people with migraines can elicit certain triggers that change of weather, change of diet, menstrual cycle things. And it may be that tiny clots going through a PFO may trigger a migraine starting in the brain. It may be that certain vasoactive chemicals, that is, substances that may cause arteries to dilate or constrict, that normally would go through the lungs and be deactivated. Again, they could bypass that function of the lungs, head into the left atrium, go up, and trigger a migraine. That's about as much as we know. And certainly migraines can be triggered by a lot of other things, but that's the what we call the pathophysiologic link hypothesis.
Wow. Okay, so let's take so migraine. We've heard there's many different causes, and obviously it's important to understand how that could potentially be linked to PFO. But the same is probably true for stroke. So let's talk about the science and maybe stroke risk factors, which there seem to be many.
So there are many different mechanisms by which people have strokes. It can be that they've got a blocked artery or a narrowed artery, a clot goes out. It could be that they have atherosclerosis in an artery in the brain that clogs off. It could be that they have an irregular heart rhythm like atrial fibrillation. A clot forms in the heart and breaks off and causes a stroke. And it really, you look at the list of different mechanisms by which people have strokes, and it's fairly lengthy. And especially as we age, these stroke risk factors like being diabetic, hypertensive, having clogged arteries, those things go up. But what started this field was really strokes in young people who were all in all fairly healthy. They didn't have these traditional vascular stroke risk factors. And the initial studies then showed that rather than 1 out of 4 having a PFO, it was up to 50 or 60% of them. So then that raised the whole question of whether strokes in younger people, absent of these traditional vascular risk factors, may be having a paradoxical embolism as the cause of their stroke.
And I've heard that called cryptogenic stroke.
So yes, and it's a little confusing. So cryptogenic is just the nice fancy medical term, meaning we really don't know why you had a stroke. And it means that after you go through an extensive diagnostic evaluation looking for all these other potential causes of stroke, and nothing really is found, and no causality for the stroke could be established, and so we say it's a cryptogenic stroke. And that's the patient group who participated in these PFO closure studies. So they had a cryptogenic stroke and they had a PFO. Now, another 50% of people with cryptogenic strokes don't have PFO, so who knows why they had strokes. That still remains one of the unknowns and challenges in stroke neurology.
Yeah, so as a patient expert, I manage an online community of PFO patients, and a lot of them find their way into our community because they don't have any answers. They are young, they're active, they've had a stroke, they're shocked, and then they find out they have a PFO, and it's very hard to make sense of all of this. So what do you suggest? Some people are entering into this, I guess, state of finding out that they have a disease or a condition through some type of neurologic event, and maybe they go to the emergency room. And then can you talk us through, the workup? It sounds like to understand how the two relate, you can't just have a cardiology workup and you can't just have a neurology workup. It sounds like you need to have experts from both teams working on you.
So the first phase of people's saga through this is they have a stroke. And hopefully they recognized it during the early phases and they had medical care, because strokes can be stopped in the middle. And initially it was all through thrombolytic drug-busting medications, TPA being one of them. But in certain people who have clearly significant strokes in large arteries like the middle cerebral artery, now certain kinds of interventionalists go in there and remove the clot, and it makes a dramatic difference in the outcome. So they go through this acute management phase, and then as part of that initial hospitalization is trying to figure out what caused the stroke, and that's where they go through a series of tests. And if they end up having the label cryptogenic stroke, and these echo studies are done and they're found to have a PFO, then the issue becomes, gee, were they related and what should I do with that PFO?
Right. So this is where they typically enter the online community.
Yeah.
Because they get conflicting advice, and a lot of patients, it's not clear. I know I received multiple opinions and they didn't agree. So we find some patients that are being prescribed, is it warfarin, different blood thinners, some are on aspirin, some are referred for device closure. And I guess if you could just tell us a little bit about the history of the field and kind of scientific evidence.
Sure.
And what we know about treatments and treatment decision making.
So if a clot is found that caused a stroke, and people want to know where it came from, and often they're very small clots, so you don't find them by examining the veins of the legs or pelvis. But it is a blood clot, so one way is medications to try to impair your body from making clots, especially clots inside the vasculature. You should make clots when you're bleeding, but some people make clots in a blood vessel, and that could break off, embolize, and cause a stroke. So aspirin, other kind of what we call antiplatelet agents are commonly used. Since it's kind of presumed that the clot may have come from a vein, then it turns out antiplatelet agents aren't so good, and that's where we use full anticoagulation, warfarin, and the novel oral anticoagulants that are out there can be prescribed. And they do reduce the risk of forming clots, and so you could still have a PFO, and you don't form clots, you may never have another issue. But obviously with some of the stronger blood clot medication, prevention clot medications, you're talking about really impairing the coagulation system, and people can either have spontaneous bleeding, or if they get into a ski accident, auto accident, they will bleed more. And sometimes so in someone who's 30, thinking about taking a oral anticoagulant for the next 50 years is not too appealing. So the alternative strategy is, if you feel that really the mechanism of the stroke was a paradoxical embolism, and the avenue by which it became a stroke was through a PFO, then that gave rise to the treatment of PFO closure, of putting in a device, as some people say, to do what God failed to do, of fusing that PFO closed, and that's how this got going over almost 15 years ago. And you, for the last 15 years, and even now, you may get very conflicting information, because it's been a difficult problem to study. Initial trials were negative, not suggesting that PFO closure really had anything to offer. And it was only in the last year, with long-term results from a clinical trial called RESPECT, that finally we got scientifically strong evidence that PFO closure is superior to taking medications to reduce the chance of having another stroke. And that's how things have changed pretty dramatically in the last half year.
Yeah, and so thinking about why it took so long to answer these questions, because I know as a patient I was frustrated. First, I couldn't believe we'd never answered them, and then the length of time that many of us in our online community had to wait to start getting answers from RESPECT. I guess people don't have strokes necessarily back to back. It can be a long period of time between strokes, and so patients had to be followed over a longer period of time. Is that correct?
Yes, and the good news is that younger people having strokes through this mechanism don't have a high rate of recurrence, but they have a palpable rate that's 1 to 2% per year. And it does, as we showed in RESPECT, accumulate even though you're on medical therapy. If you weren't on medical therapy, the rate would probably be double that. So that's a relatively low event rate, and doing PFO closure hypothesized to reduce that rate by more than 50%. That's a relatively small difference. And so it means the study design had to have longer term follow-up than we originally thought it did. And so that was one of the challenges of coming up with scientific evidence, is really need people to A, volunteer to be in a study, and B, stick with it for a long time. And that produced other problems that led to the length.
So answering the scientific question, we have the trial design. You had some patients who stayed on their medical therapy, and then you had some that were what you call randomized, so random occurrence to receive a device, meaning you can't choose, the patient can't choose. It's a computer or a gumball machine type of
randomized trial is tough sometimes because number one, to do a randomized trial, the community, speaking broadly, has to feel that it's really, we're in equipoise. We've got two treatments and we don't know which is best.
Okay.
And so that's where randomization becomes important, and randomization helps spread out evenly other factors. Everyone's different.
So bias.
So you want to get rid of any bias. Yeah. And it's tough because people are seeking answers and they think the new therapy may be the best therapy. And if we don't have the scientific proof to really say that's true, and you have to be randomized, that's tough for people when they're randomized to the traditional treatment. They think, gee, I'm getting not the latest and greatest, but it's because we don't know it's the greatest, and that's why it has to be studied. And that was certainly the case with PFO closure.
Okay, I want to keep talking about respect, but we're going to come back to patient preferences because I think in the case of PFO and stroke and the decision making, that's really important. But what were the findings of the RESPECT trial?
So the RESPECT trial, after long-term follow-up with people now being followed for an average of 5 to 6 years, and some of them had been in the trial for 12 years, we showed that there was a 50 to 60% reduction in recurrent strokes. And so after 5 years, that difference was fairly palpable. It meant a difference between about 6 to 7% of people having recurrent strokes, now reduced down to about 3%. And the people who have recurrent strokes in the PFO closure arm, you sort of say, well, why did they have them? And they probably didn't have originally, and certainly not in recurrent, a PFO-related stroke, and their PFOs may have been incidental, or some of these people, enrolled in the trial when they were 58, and now they're 72, and they develop other reasons for strokes. So that's why randomization is important. That's why long-term follow-up is important. And that's why the trial is really designed for people between 18 and 60, because we knew when you get up to 70, then all these other potential stroke risk factors come. So RESPECT demonstrated, first of all, efficacy, that the PFO closure with this particular device really reduced the chance of recurrent stroke. Okay. And that was statistically and clinically meaningful. And then the second aspect of that is the whole safety issue.
Okay. So to be clear, this trial studied one particular device.
Yeah.
Okay. And so how generalizable is that to any other device that's out there?
It's not. It really is not. And there was a previously published trial called Closure, used a different device, and that device had some problems. It caused atrial fibrillation. There are clots on the device, and so the device itself, in some poor people, caused recurrent strokes. And so devices are not all the same, number one.
Okay, so a patient comes into your office. How do you frame this conversation around the risks and benefits and what you learned in RESPECT, and then taking in their personal preferences? Because I know in our online community, I hear from patients who are, they would do anything to get off the blood thinners. It's affecting their quality of life. They don't like managing their INR. They don't like blood draws. They don't like managing their diet. They're at risk in contact sports. Then there are other patients that really feel like, if I'm doing okay on medical therapy, I don't want to live with a device the rest of my life. So talk to me about how you kind of engage in that risk-benefit conversation with a patient.
So I think, first of all, and you really started this off by talking about the heart-brain connection. And so people who've had a stroke and are found to have a PFO, they really need the combined experience and expertise from cardiology and neurology. So like we have a PFO clinic where we see people together. And that's important too, because then you get more consistency of what we're talking to about, and answering questions from patients and families. And so we work through this. Did you have a cryptogenic stroke? Did you have a PFO? Were there other confounding factors that might influence decisions? And then we talk about the results of the clinical trials, and then we talk about the risk versus benefit of the two approaches. And certainly medical therapy is effective at reducing recurrent stroke risk, and may be fine for certain people. PFO closure is a procedure, and some people really hesitate having a procedure and having a permanent device put in their heart. So we talk about the procedure and what it's like, and the risks and the benefits, because it's only through really being given this information that people can make an informed decision on their own, and they can have their own preferences enter into that after they understand what the facts of their case may be, and the literature, and that now, unlike say more than 6 months ago, now there's an FDA approved device specifically for this indication. And so all that is, I think, part of the decision making that needs to go on.
Okay, so as a patient, framing that is based on my personal characteristics, what can I expect my outcomes to be? Which you can't be exact, but you can say, based on what we learned in this trial, and based on what we know about people, about you, and then you weigh all those things with the personal preferences and let the patient engage in decision making.
That's right. And as you mentioned previously, blood thinners are effective at reducing the risk of recurrent stroke, and especially the stronger ones. But maybe someone has either a social activity or a professional type of activity where they get a lot of trauma. They could have major bleeding, and if you're on a blood thinner, especially if you get head trauma, that could be a very dangerous. So they may go more down the road of getting closure because they really don't want to be on strong blood thinners.
So what kind of adverse events did the RESPECT trial study?
Yeah. So you have to think of, we studied the adverse events in both groups of people, those who are on medications as well as those who had PFO closure. Those with PFO closure obviously have two different kinds of potential adverse events that need to be studied and quantified. Those are related to the procedure itself, and then secondly, of having a device in your heart long term. And so that's where RESPECT was very clear in gathering a large amount of follow-up in over 400 people who had PFO closure. Unfortunately, the procedure is fairly safe, but there were several people who had major complications, perforation of the heart where they get blood around the heart, and one person had to have that drained. Fortunately, did fine. Bleeding from the access site, even though it's up a vein, not an artery, and the bleeding risk is therefore less. Bleeding still can occur. And so there are what we call serious adverse events, and that occurred in about 3 to 4% of people who had PFO closure. Fortunately, most of the adverse events were readily managed and didn't have any long-term consequences. Okay. And then we turned to long-term, and certainly putting a device in the heart in this location, some people have palpitations, and knowing if some people go on and have an arrhythmia called atrial fibrillation is important. And we saw a slight increase in the number of people at AFib with devices versus those people long-term in the medical arm. But again, as you get age, atrial fibrillation turns out to be fairly common. And so all the procedure-related AFib, which was, I think, 4 or 5 people, was transient, and they didn't have any problems. After the procedure, actually those in the medical arm and the device arm had an equal incidence of atrial fibrillation. Now, 2 people in the medical arm had atrial fibrillation and had a stroke as a result.
Wow.
So it just shows that other stroke mechanisms can come along, and that's independent of having a device or not. So We presented all the safety data, first of all, to an expert FDA advisory panel, and they voted all but one that the device was clearly had strong evidence for safety, and I think that's true. But it's important to realize a couple things. Number one, it is a procedure, and there's always a potential for a serious complication. So you want to have it done by someone who knows what they're doing, who's experienced. Secondly, monitoring someone's status after a device is important to make sure it heals up okay, and there are no problems. And it's very important to realize that this is a very targeted therapy for one stroke mechanism.
Right.
And so you can't walk out of this saying, well, I'm cured, because we can't definitively prove in the majority of people that their stroke was from a clot going through the PFO. So universally, we recommend a comprehensive secondary stroke prevention strategy for everyone. So if you have mild hypertension, keep it treated. If you're a couch potato, start exercising. If you're able to take a low dose aspirin, we recommend that for everyone long term because it covers other potential stroke mechanisms. So prevention of another stroke is not just with PFO closure, that's one part of a comprehensive strategy.
Okay, so that's really important. So even if you close your PFO, you still have to manage all your other stroke risks. It is not a cure-all.
Yep.
Okay. We're getting close to the end of our time of this broadcast, but I think maybe we want you to come back and talk more specifically about the procedure itself and what to expect and some of the common questions that patients have related to just the procedure itself. And I think today we focus mostly on understanding mechanisms and diagnosis and treatment decision-making, which is important. So I want to go to some of the questions that we had patients write in. So we did get questions about shunting, and that's where, well, you're the expert. I'm not going to explain it. You say what shunting is.
Well, shunting is a medical term for blood flow that's in an unusual, unexpected pathway. And so normally your right and left side heart chambers are separated by walls in both the ventricle and the atria. And if there's an opening between them, then blood could go between the two, and that's what we refer to shunting, and we can see that with a variety of medical imaging.
Okay, so one source of shunting is your PFO.
Mm-hmm.
But what happens when you actually close somebody's PFO and then they're shunting after you've closed the PFO?
Well, it should stop. We would expect complete closure, and we looked at that 6 months in respect. Approximately 75% had complete closure, and another 15+% of people had almost complete closure with a few bubbles. So some people did have persistent shunts that do need to be evaluated of whether hey, there's another hole that was missed, or whether the device just didn't hold it completely. But in the majority of people having closure with this device, over 90%, the closure is adequate to block any clot from crossing.
Okay. And so are you aware of patients that have actually had to have, I guess, a repair after closure? And I know you can speak only specifically to this RESPECT device or Amplatzer device.
It is. If people really have large shunts that remain, then some consideration should be made putting a second device in there to complete the closure and to really understand if people have significant shunts. It really typically means having another of those transesophageal echocardiograms that really allow you to see what's going on in that area of the heart. Is the device didn't close it completely, or is there something else?
Okay. And quickly, what's the device made of?
So the device is made out of really two materials, a medical cloth that's in the middle of the device, and the device is primarily composed of a wire, a metal wire that's woven into a double disc configuration with a center disc or center connector that connects the two. And the metal is an alloy called nitinol, which is very commonly used in a variety of medical devices, and it's an alloy of titanium and nickel.
Okay. So even thinking about if somebody, the very small fraction of people that may end up needing a repair, we don't have good data. If you put two devices in and metal rubs metal or rubs other heart structures, it seems like you certainly don't have the 500 patients that you followed for 5 years plus in RESPECT. So that's a consideration.
So fortunately, that doesn't happen too often, but
Okay.
it is true, putting a second device in. And one has to think carefully about that. Usually the devices don't interact. Fortunately, this area of the heart is far away from heart valves, so you're not interfering with other structures of the heart, and it's not in the main pumping chambers, so cardiac function usually remains totally normal.
Okay, so that brings us to another patient question.
Yeah.
The eustachian valve, what is it, and how does it affect your decision making around closing PFO or risk related to PFO?
So that's a structure in the right atrium that basically is like a flow divider. It promotes the direction of flow coming up from the lower body through what the big vein called the inferior vein cave, and it directs it at the PFO. Again, go back to when we're in our mother's womb, you want that kind of directionality to get the flow to go across the PFO. So it's just one of the findings that you can see with ultrasound in the right atrium, and it's sort of another of the anatomical features that I would say is not a major one like the PFO itself or an atrial septal aneurysm, but a minor anatomical feature that often gets characterized in certain people.
Okay.
It's not a disease or an abnormality that has to be chopped out.
So does that introduce additional risk, or
we really don't have
what do you
enough
think about
data
it?
about that?
So we hear from patients, somebody told them they had a prominent eustachian valve.
Yeah,
Well,
I wouldn't be bent out of shape about that. That's just a really a further characterization that yes, it's been associated with people who have PFOs with strokes, but it's not a hardcore finding that that's been really studied in terms of whether it's that important or not.
Okay, we're going to do one more question, then we're going to need to bring our broadcast to a close. But how does pregnancy factor into decision making? So if you're diagnosed and your PFO is open, what happens and how do you think about this? And then I know there are people that want to know if they underwent a closure, is it safe to get pregnant?
Yeah. So
you've had a stroke.
So a young woman who's had a stroke is found to have a PFO, and the complete evaluation by a team, a neurology, cardiology team, has a high suspicion the PFO was part of the enabler of that stroke. It would be wise for someone to have their PFO closed before they get pregnant again. There are changes in the cardiovascular physiology and the clotting in people who are pregnant, and taking blood thinners during pregnancy. Certain ones like warfarin are strictly contraindicated, especially early in pregnancy, because they can lead to fetal abnormalities. So PFO closure before pregnancy certainly would make a lot of sense in someone who had a cryptogenic stroke associated with a PFO before. Otherwise, having a PFO device in during pregnancy should not be an issue and shouldn't alter anything about the pregnancy itself or delivery.
How long would patients be advised to wait after a PFO closure to try getting pregnant?
Oh, I think the first month following a PFO closure, for the first week, first of all, we say, take it easy, no heavy lifting, because we want things to heal up in your leg vein that was used. After that, we say you can do just about anything. In the first 6 weeks, there are about maybe 5% of people will feel some flip-flops of their heart, what we call palpitations, and they usually are transient and they go away, and some people are bothersome. So I would say get through that period, get through 6 weeks where you know you're not having any other issues, and that it's healing up, and that you've had a follow-up echo that shows the device is where it should be, the closure is reasonably complete. And so I would say wait 6 weeks or so.
Okay. So this will be the last question for you. How do patients find people that are considered to be experts in PFO?
It's a good question because it's number one. I would recommend that you really need to find a team, and maybe they don't meet together, but a neurologist and a cardiologist, because the neurologist can really help you think through your stroke that you had, the evaluation, the potential cause, and can render opinion about whether the PFO is out there. Now, people are just learning about the long-term results from RESPECT. So, and we hope to have a major publication out in the next month that will continue to spread the knowledge. In terms of a cardiologist, an interventional cardiologist, we do come in different flavors, and some people do specialize in what we call structural heart interventions. We're closing different kinds of holes, putting valves in. It's a different skill set. So if you do meet with an interventional cardiologist, it's a reasonable question to ask them whether it's his or her experience, how many cases have they done, what do they think about your situation, and give you good answers to any questions you want to ask them.
Okay. Excuse me. And any red flags? What if you walk in and somebody says, you absolutely must close your PFO, or absolutely don't close your PFO? Does that concern you?
That would concern me, because it really is a decision that can be nuanced. That isn't, you must do anything. Mm-hmm. It's your decision. And so I would consider red flag if you felt any sense of being pressured, or you have to get this done next week or something like that. That's just, I think, bad form. Or if you haven't seen a neurologist and cardiologist says, so you really don't need to see a neurologist, I would back away from that, because we are not trained to diagnose strokes, mm-hmm. to work through the various mechanisms. And there are some very unusual causes of stroke we don't even think about, but a good stroke neurologist will. So I strongly would say that's another red flag.
Okay. So I would love to have you back sometime. Maybe we can talk a little bit more about this. And I see we've got more questions pouring in, and unfortunately we're just out of time in this particular broadcast, but maybe you come back and we can talk a little deeper and more about the procedure and what to expect. But thank you, Dr. John Carroll from University of Colorado Hospital, and I'm Bray Patrick-Lake, a patient expert. You can find us online at the PFO Research Foundation Facebook group, and we'd be happy to have you join our online community of patients there. So thank you.